Assalamu alaikum and a very good afternoon to all of you. Myself is Dr. Shama Alamgir, PG scholar from Department of Tahfuzi wa Samaji Tib. In the last session, I have discussed about the Journal of Patient Experience. Now I will discuss the research article published in the journal Patient Satisfaction with Medical Services Provided at Unani Medicine Hospital, Bengaluru, a cross-sectional study by Dr. Ejaz Ahmed, PG scholar, and Dr. Malik Itrat, assistant professor, Department of TST and IUM Bengaluru. The general guideline for the research article is the word count limit is 3,000 word, and this research article include approximately 2,322 words. The headers must include abstract, introduction, method, results, discussion, limitation, conclusion, and references. This research article includes the headings abstract, introduction, method, result, discussion, conclusion, references, but the limitation of the study is not mentioned in the separate heading. It is included in the discussion section. The limit of tables or figures is 4, and this article includes 3 tables. The article processing charge is $1,200. Moving toward the title of the research article, it is Patient Satisfaction with Medical Services Provided at Unani Medicine Hospital, Bengaluru, a cross-sectional study. And the suggested title for this research article is the Patient Satisfaction with Outpatient Department Services Provided at Unani Medicine Hospital, Bengaluru, a cross-sectional study. The guideline for the title is it should be concise, descriptive, unambiguous, accurate, and reflect the precise content of the manuscript. The title of the research article is concise and reflect the precise content of the manuscript, but the title doesn't include the study is OPD based and it is not mentioned in the title and it makes the title less accurate. So I have suggested this title. देखिए and the guideline for abstract, this is the abstract of the paper. The abstract should be unstructured and the limit for word in the abstract is 175 words, and it should concisely state the purpose of the research, major finding and conclusions. The abstract of the research article is unstructured and it states the purpose of research clearly and it states the major finding, and but the abstract of the research article is of 252 words, which exceeds the word limit, that is 175 words. The guideline for keywords is include a minimum of 4 keywords listed after the abstract, and the number of keywords here is 4. While numerical scores are provided, there is no mention of the scales range. In the abstract, it has discussed the finding of the study, but it has not discussed the scales range. It is mentioned in the abstract that patients have been taken from various service delivery point of the facility, but it has not mentioned from which area the patient has been taken. The abstract doesn't specify how patients were selected. That is the sampling method of the study. This is the introduction of the article. The strength of the introduction is the introduction clearly states why the patient satisfaction is crucial and connects it to the Unani system of medicine. It identifies a clear gap in research, lack of studies on patient satisfaction in Unani hospitals. The final sentence explains the purpose of this study by highlighting the gap in the existing knowledge and how this research aims to fill it. The weakness of the introduction section, is the study setting is only mentioned in the title but is not expanded in the introduction. The specificity of the study population is missing. It doesn't include, matlab, does it include only OPD patients, IPD patients, or both? The material and method section, the study setting and population. The strength of this portion of material and method is the study clearly states that it was conducted at the NIM hospital in Bengaluru, describing a diverse patient catchment, that is local adjacent cities and neighboring states, and it has the clear inclusion and exclusion criteria, that is only patients aged greater than 18 years attending the OPD were included, and those who too ill or who refused were excluded. The weakness of this portion is it is limited to OPD only. Although the hospital offers inpatient services as well, the study is restricted to the OPD. This limits the ability to generalize findings to all patient groups within the facility. Study design and sampling. A descriptive cross-sectional design is suitable for assessing patient satisfaction at a single point in time. The sample size calculation is mentioned by the formula given in the paper. The weakness of this portion is it has used a convenience sampling. Using a non-probability sampling method may introduce selection bias or after the generalizability of the results. The departmental representation. While patients were selected from various OPDs, the method does not ensure random or proportionate representation from each department. As in my synopsis, I have mentioned this division of the patient from different departments. The previous study that is done by the Dr. Ijaz has not differentiated the from which OPD how much patient he has taken from which OPD has not mentioned. Study tool and scoring method, and the use of the standardized instrument. The PSQ-18 is a validated questionnaire that covers 7 important domains of the patient satisfaction, and the detailed scoring process. The description of how scores are generated is clear and allow for consistent interpretation. Uh, it is not mentioned whether the PSQ-18 was adapted or validated for the local context or language, which is important for ensuring its reliability in this setting. Now moving toward the results section, the author has shown the result in 3 tables. In the first table, it has it has written that general satisfaction. This domain reflects overall impression of care and has the lowest mean score among all the domains. In technical quality, indicates patients feel confident in the healthcare providers, clinical expertise and thoroughness. In interpersonal manner, the mean score is 4.94, that is I think maximum among all. Along with communication, this is the highest rated domain, suggesting patients greatly appreciate the respect, empathy and kindness shown by the staffs. Communication tied for the highest satisfaction score, highlighting that patients find the clarity of explanations and providers listening skills to be excellent. In the financial aspect, the patient generally consider cost and billing policies fair, though the slightly higher standard deviation suggests some variability in financial experiences. Time spent with the doctor, patients feel they receive adequate consultation time with minimal variation in the responses. Accessibility and convenience is still high but lower than other domains, indicating some room for improvement in areas like scheduling, traveling, or waiting times. For overall satisfaction, the mean score is 4.82, and it reflects a generally positive perception of care across all measured dimensions with low variation among respondents. The table 2 discuss the demographic data of the patients. It is age, all age show similarly high satisfaction score. Men and women report nearly identical mean satisfaction. All religious groups exhibit comparable satisfaction level, well above the 4.5, 4.7. Urban and rural patients both express high satisfaction. Across different socio-economic classes, mean score remain consistently above 4.7. In table 3, and the author has discussed about the present health problem related with the satisfaction, how present health problem of patient is relatable with the satisfaction of them. It covers various conditions like cardiovascular, GIT, respiratory, neurological, musculoskeletal, and metabolic disorders. Although mean score varies slightly, no significant differences in overall satisfaction appear among these diagnostic categories. For treatment effectiveness, is categorized as highly effective, moderately effective, minimally effective, or non-effective. A patient who perceived treatment as highly effective reported the highest satisfaction, whereas those who found it less effective has notably lower satisfaction. Duration of response to treatment compares satisfaction based on how quickly patient felt improvement. That is, if, for example, within 30 days, within 60 days, or have no effect. The mean scores are high across all time frames, and no major significant difference emerges based on response duration. For the side effects during treatment, patients reporting no side effects have a markedly higher satisfaction score than those who experience side effects. This aligns with the overall finding that better treatment experiences correlate with higher satisfaction. The strength of the result is the results are organized into three clear tables that show satisfaction scores for different service domains, demographic groups, and clinical characteristics. Each table provides numerical data and p-values which show where significant differences exist. The presentation is comprehensive, covering various factors that can influence patient satisfaction. The weakness of the result section is the result do not clearly explain the scoring scale, that is 1 to 5, making it harder to interpret what high or low scores means. The narrative could be better integrate and explain the statistical findings and potential biases across the tables. So this discussion section, the strength of the discussion section is the author clearly restates the score result, that is high patient satisfaction across all measured domains, with interpersonal manner and communication scores highest and general satisfaction slightly lower. The author acknowledged that direct comparison with other Unani studies are not possible due to lack of published research, and thus they compare with Ayush based studies, which is logical given the shared context of alternative or traditional medicine. They cite both supportive and contradictory studies showing an effort to situate their finding in a broader research landscape, and the author clearly acknowledged that convenience sampling and single hospital setting, noting that these factors limit generalizability. They call for larger, more randomized studies across multiple Unani hospitals for better assess patient satisfaction. And they recognize that improving service quality in Unani hospitals could boost trust and utilization of traditional medicine. The weaknesses are, although they emphasize high satisfaction in all domains, they could have quantified the contrast between highest and the lowest domain. The discussion focuses heavily on the descriptive aspect of the finding without deeply exploring why certain domain might be higher or lower in satisfaction. The discussion does not address the potential for cultural or regional differences between the hospital studied, that is a tertiary hospital, NABH accredited Unani facility. They do not specify how future studies might improve methodology, that is, a stratified random sampling. And the discussion does not detail a specific actionable recommendation for hospital administrators, such as strategies to maintain interpersonal and communication scores or to address the relatively lower general satisfaction domain. They could have elaborated on how NABH accreditation standards specifically influence patient satisfaction, guiding other Unani or Ayush hospitals aiming for similar accreditation. In the conclusion section, the conclusion effectively summarizes key findings, emphasizing high overall satisfaction and the role of treatment effectiveness and a strong doctor patient communication. While the weakness is it lacks specific details on which aspect of general satisfaction require improvement and does not mention study limitation or suggest future research directions. The author has mentioned the acknowledgement, the declaration of the conflicting interest, and the funding details. That is, the author received no financial support for the research, authorship, or publication of this article. These are the references. The guideline for reference is it should be limited up to 40 and it should follow AMA style. The number of references are 26, and I have a confusion which I want to discuss with you all, that what is AMA style referencing different from Vancouver style, and if yes, then in what aspects? Yes, sir.